Good day, everyone. I'm your tutor today in general and systemic pathology, particularly on the topic on head and neck. Our reference is Robinson-Cotran, chapter 16. As much as I want to meet all of you personally, it seems that for now it's quite impossible. One, we are doing the class virtually, and two, I'm just recording this lecture. But let me just press on one thing that I want you to know, that my heart is with you. All that I want in joining the teaching force of UNP College of Medicine is to convey, even just for this class or batch, what I know. That even just 1 or 2 points that I could contribute in your medical board exams, I would be very happy. Just to give you a glimpse of who I am Dr. Cheryl Lalas Ronas. I hail from Pangasinan, married to an Ilocano from Isabela. I am a medical technologist for almost 12 years before I decided to study medicine. So yes, I was 36 years old when I started in medical school, UNP. There were only 11 of us in our batch 2013. That's not too long ago. 2014, I did my internship at Adventist Medical Center, Manila. And 2015 February, I passed the physician's licensure exam. 2015 to 2019, 4 years training in Ilocos Training and Regional Medical Center in the Department of Pathology. And with God's help, I passed the Anatomic and Clinical Pathology Diplomate exam in March 2020, just a few days before the lockdown. Now, why am I telling you this? Because I want to tell you that our tutors did not lie when they told us that going to medical school will take you around 10 to 11 years before you start your own practice. For me, I started in 2009 in medical school and finished my specialty training in 2019. I'm not here to discourage you, rather I'm telling this to encourage you. There may be some point in your studies that you feel low, but move on. There may be bullies in the hospital during your clerkship. Move on. There may be sleepless nights during your specialty training. Move on and persevere, and you will reach your goal or your dream. Some have already gone ahead. If they were able to do it, you can do it too. Remember this, in school there may be competition on who gets a higher grade, but in the ideal world, what we need is a team approach in healing the patient. Some of you will become an internist, surgeon, gynecologist, radiologist, pediatrician. Lay aside any competition or differences, but work together for the good of the patient. The patient doesn't really care if you are the summa cum laude or the magna cum laude. A quotation runs like this: our patient may not really care how much you know. What he or she wants to know is that you care. So, thank you for giving me a few minutes of your time. Now, before I get to the main lecture, I would like to give you an assignment that I believe would help you know more about your learning style. How do you learn better? Do you like diagrams or pictures? Do you enjoy listening to lectures? Do you learn better if you do the skill? This will take around 10 minutes. Just follow the instructions that I will send to your email. Now for the lecture proper, I am assigned the chapters on head and neck, lower genital and male genital tract, endocrine system, and skin. What I plan to do is to do it in a question and answer form. I will give you freedom on what you would like to do. If you want to still do a trans, it's fine with me, but I will give you the Microsoft PowerPoint of my lecture. Our quizzes and exams will all come from them. I have to warn you though that I may make an incorrect statement, so if you are in doubt or confused, remember, don't hesitate to email me or better still, to read it directly from Robin's. Note that page and send me a message so we can learn together. And at the end of my recorded lecture review, I will give a 20-point quiz. Multiple choice, our favorite, just to hone your testmanship. Okay, let's start. So for our first slide, these are caused by focal demineralization of tooth structure, the enamel and dentine, by acidic metabolites of fermenting sugars that are produced by bacteria. These are dental caries. So that's how we're going to go through these slides. I hope you are fine with that. Next, this substance is incorporated into the crystalline structure of tooth enamel, forming fluoroapatite, which contributes to the resistance to degradation by bacterial acids. This is fluoride. Next, inflammation of the oral mucosa surrounding the teeth. This leads to dental plaque and calculus. Gingivitis. A sticky, colorless biofilm that collects between and on the surface of the teeth, contains a mixture of bacteria, salivary proteins, and desquamated epithelial cells. These are dental plaque. And mineralized dental plaque are called dental calculus or tartar. Inflammatory process that affects the supporting structures of the teeth. This is associated with the following bacteria. This is periodontitis. Periodontal infections can be the origin of important systemic diseases, including infective endocarditis in the heart, pulmonary and brain abscesses. So this slide shows how periodontal disease affects our body, that the bacteria can go to different parts of our body. Next, these are exceedingly painful superficial oral mucosal ulcerations covered by a thin exudate and rimmed by a narrow zone of erythema. This has an unknown etiology. These are called Aphthous ulcers or canker sores. A submucosal nodular mass of fibrous connective tissue stroma that occurs primarily on the buccal mucosa along the bite line or the gingiva. These are irritation, fibroma. Next, an inflammatory lesion typically found on the gingiva of children, young adults, and pregnant women. This is called pregnancy tumor, and microscopically highly vascular proliferation of organizing granulation tissue. This is pyogenic granuloma. Next, these arise from a long-standing pyogenic granuloma or de novo from cells of periodontal ligament, red, ulcerated, and nodular lesions of the gingiva, and the peak incidence in young and teenage females. These are peripheral ossifying fibroma. Now, this may sound very like for the residents already level, so these are just good to know. Next, we have the reactive inflammatory lesion of the oral cavity with a striking aggregation of multinucleated foreign body-like giant cells separated by a fibroangiomatous stroma. So if you see my cursor, these are the multinucleated cells, and we call that foreign body-like giant cells. And this is described as peripheral giant cell granuloma. Next, these are herpetic infection caused by herpes simplex virus type 1, with abrupt onset of vesicles and ulcerations of the oral mucosa, particularly the gingiva. If you notice there, the whitish pinpoint lesions. These are acute herpetic gingivostomatitis. And the cells in acute herpetic gingivostomatitis sometimes develop these eosinophilic intranuclear viral inclusions, or several cells may fuse to produce giant cells, these multinucleate polykaryons. And these are seen in what diagnostic test? Diagnostic test for herpes virus. We have the Tzanck test. So next, the herpetic lesions that appear as groups of small 1 to 3 millimeters vesicles on the lips. These are herpes labialis. There are three major clinical forms of oral candidiasis. These are pseudomembranous, erythematous, and hyperplastic. And the pseudomembranous form is the most common and is also known as thrush. So these are superficial gray to white inflammatory membrane composed of matted organisms enmeshed in a fibrinosuppurative exudate that can be readily scraped off to reveal an underlying erythematous inflammatory base. So again, the code here, or the important word here or note here, is that it can be scraped off. These are thrush. Now there are oral manifestations of some systemic diseases. We have this. This is in a table form in Robbins. So in scarlet fever, there is an oral change. And this change is, there is fiery red tongue with prominent papillae. These are often described as raspberry tongue. White coated tongue through which hyperemic papillae project, and these are also called strawberry tongue. Next, measles. The oral change in measles. We have the spotty enanthema in the oral cavity often precedes the skin rash. The ulcerations on the buccal mucosa about stents and duct produce the Koplik spots. So those are the important words there. Koplik spots, the stensin duct, oral change in measles. In infectious mononucleosis, the oral change is, there is acute pharyngitis and tonsillitis that may cause coating with a gray-white exudative membrane. There's enlargement of lymph nodes in the neck, palatal petechiae. Next, we have diphtheria, where we have the characteristic dirty white fibrinosuppurative tough inflammatory membrane over the tonsils and retropharynx. So take note of that again, the membrane, inflammatory membrane that forms in diphtheria. HIV can also produce oral change or oral lesions. This is the HIV patient is predisposed to opportunistic oral infections, particularly herpes virus, candida, and other fungi. The oral lesions of Kaposi sarcoma is seen here in our slide, and HIV can also produce the oral change of hairy leukoplakia. We will discuss that in the following slides. So in this picture, the seen here is the oral lesion of Kaposi sarcoma. Next, in Lichen planus, The oral change is there are reticulate lace-like white keratotic lesions that sometimes ulcerate and rarely form bullae or like a blister. They are rarely is the sole manifestation for lichen planus. Next, systemic disease that form an oral change is pemphigus. The oral change, the patient can have vesicles and bullae prone to rupture, leaving hyperemic erosions covered with exudates. So we have these different diseases with characteristic blister. So this is the skin. For subcorneal, that is pemphigus foliaceus. For suprabasal, remember this is your basal membrane, or sorry, basal layer of the skin, epidermis. We have the pemphigus vulgaris, and then for the subepidermal, so this is epidermal, this is dermal, so this one. If the blister is located here, it is for bullous pemphigoid. So for bullous pemphigoid, that is subepidermal, the oral lesions resemble those of pemphigus but can be differentiated histologically. So like what we just mentioned in the previous slide. Next is erythema multiforme. The oral lesion is maculopapular vesiculobullous eruptions that sometimes follows an infection. It can also follow ingestion of drugs, development of cancer, or a collagen vascular disease. And when there is widespread mucosal and skin involvement, this is referred to as Steven-Johnson syndrome. Next, for pancytopenia, or agranulocytosis and aplastic anemia, several oral infections can appear in the form of gingivitis, pharyngitis, tonsillitis, and may extend to produce cellulitis of the neck. And when that happens, it is referred to as Ludwig angina. In leukemia, there is depletion of functioning neutrophils. The oral lesions may appear like those in pancytopenia, the previous slide. For monocytic leukemia, leukemic infiltrations and enlargement of the gingivae, often with accompanying periodontitis. Melanocytic pigmentations. The oral change may appear in Addison's disease, hemochromatosis, fibrous dysplasia of bone in Albright syndrome, and Pew-Jeghers syndrome with gastrointestinal polyposis. So these diseases can present with melanotic pigmentation. And as we can see in this picture, it is on the patient's lip. For phenytoin or dilantin ingestion, the oral change may be so striking. There is enlarged fibrous enlargement of the gingiva. In pregnancy, there can be a friable red pyogenic granuloma protruding from the gingiva. And as mentioned a while ago, it is a pregnancy tumor. For Rendu-Osler-Weber syndrome, it is an autosomal dominant disorder with multiple congenital aneurysmal telangiectasias. So with aneurysmal, if we say aneurysms, remember they are weakened vessels, and these are dilated for telangiectasias. This picture shows the appearance of these aneurysmal telangiectasias beneath mucosal surfaces of the oral cavity and lips. So in this picture, it's on the lips. So now we have a distinctive oral lesion on the lateral border of the tongue. So while I'm reading, can you imagine there's an oral lesion on the lateral border of the tongue that is usually seen in immunocompromised patients, and it's caused by Epstein-Barr virus. Grossly, there are white confluent patches of fluffy hyperkeratotic thickenings that cannot be scraped off. These are hairy leukoplakia. So a while back, we mentioned about something that is not scraped off or can be scraped off, sorry. Those are thrush. And for this that cannot be scraped off, it's hairy leukoplakia. And microscopic appearance of this consists of hyperparakeratosis and acanthosis with balloon cells in the upper spinous layer. So me personally, I'm a visual learner, so I put, if possible, a picture on the slide to help us picture these conditions. So we have this hairy leukoplakia. So this slide shows the gross picture of the hairy leukoplakia and the microscopic picture where we have the hyperkeratosis and parakeratosis, and we have these balloon cells or enlarged cells like edematous cells on the spinous layer. So next we have red, velvety, possibly eroded area within the oral cavity that usually remains level with or may be slightly depressed in relation to the surrounding mucosa. These are erythroplakia. And we have intermediate form of lesion characterized by both leukoplakia and erythroplakia. We have leukoerythroplakia. Now, what gene mutation is frequently involved in classic squamous cell carcinoma of the oral cavity? We have the mutation on the TP53 gene. Now, there's a cyst that originates around the crown of an uninterrupted tooth and is thought to be the result of fluid accumulation between the developing tooth and the dental follicle, most often associated with impacted third molar or the wisdom teeth, and microscopically these are lined by a thin layer of stratified squamous epithelium. This is a dentigerous cyst. So a cyst, another one, is lined by thin layer of keratinized stratified squamous epithelium with a prominent basal cell layer and a corrugated epithelial surface. So I believe you've studied this way back in histology class, this stratified squamous epithelium, and if we say the epithelial surface, so we have this, the stratified squamous epithelium, the prominent basal layer, and then the corrugated epithelial surface. We have this odontogenic keratocyst, which are now called keratocystic odontogenic tumor. Good to know. We have a syndrome where there are nevoid basal cell carcinoma syndrome associated with mutations in the tumor suppressor gene PTCH located on chromosome 9. This is Gorlin syndrome. There's another cyst, inflammatory in origin, found at the apex of teeth. So a while back we have the unerupted tooth, the wisdom tooth. For this one, it is at the apex of the teeth. Result from long-standing inflammation of the tooth or by trauma to the tooth. This is a periapical cyst. And over time, the periapical cyst will form a lesion with granulation tissue. These are granulation tissue, and subsequent epithelialization may lead to the formation of a cyst. And this is radicular cyst or periapical granuloma. The most common type of odontogenic tumor arises from epithelium but shows extensive deposition of enamel and dentin. Most common type, odontoma. There. Next, we have variably sized islands. So this is described, the microscopic description of this tumor. Variably sized islands of odontogenic epithelium whose peripheral palisading tall columnars. So watch my cursor as I point to the palisading or the fence-like position or pattern of tall columnar cells display reverse nuclear polarity. So when we say nuclear, the nucleus, polarity, they are positioned opposite the basement membrane. So here you see the clear or the subnuclear vacuoles, and the nucleus are positioned on the opposite of the basement membrane. So these are palisading tall columnar cells display reverse nuclear polarity and subnuclear vacuoles, and the center are islands of loose textured stellate or star-like epithelial cells, often with microcysts or small cysts, cystic spaces. So this is the clinical picture of the patient with a mass. This is the radiographic image and then the microscopic findings. This is ameloblastoma. The major offenders causing infectious rhinitis. Now we go to here at the nose. Rhinitis is adenovirus, echovirus, and rhinovirus. This is a hypersensitivity reaction to one of a large group of allergens, most commonly the plant pollens, fungi, animal allergens, and dust mites. This is allergic rhinitis or hay fever. So the symptoms, runny nose, sneezing, coughing, itchy episodes, and then we have frequent headaches, and hives. For chronic rhinitis, these are repeated attacks of acute rhinitis. There is superficial desquamation or ulceration of the mucosal epithelium. This is the mucosa. So there's ulceration. At this picture, I was not able to get a more clear picture of ulceration, but for ulceration, it will be denuded here at this part, supposed to be, and a variable inflammatory infiltrate. Variable, so you can see different types of inflammatory cells, but for this picture, as you can notice, there are a lot of reddish inflammatory cells here, so it's more of eosinophils. Oh, for this picture, we have nasal polyps, which consists of edematous mucosa having loose stroma. So if we mention mucosa, this is the mucosa, and stroma is the supporting structure, infiltrated with a variety of inflammatory cells, including neutrophils, eosinophils, and plasma cells, with occasional clusters of lymphocytes. So when we see this in the microscope, we diagnose this as nasal inflammatory polyps or nasal polyps. Next, we have a benign, highly vascular tumor. So these are the blood vessels, highly vascular tumor that occurs almost exclusively in adolescent males who are often fair-skinned and red-headed. nasopharyngeal angio or blood fibroma, fibrous part. So angiofibroma from the nasopharynx. So nasopharyngeal angiofibroma. Next is inverted endophytic papilloma. These are papillomatous proliferation of squamous epithelium that invaginates into the underlying stroma. So they invaginate inside, not outside. Okay. So they are called inverted. And sinonasal papilloma are also referred to as Schneiderian papilloma. Good to know. Next, two more that arise from the neuroectodermal olfactory cells present within the mucosa, particularly in superior aspect of the nasal cavity, which are composed of nests. So when you read again this description, nests or groups of cells, nests and lobules of well-circumscribed or well-delineated cells that are separated by fibrovascular stroma. Fibrous and vascular, so there are blood vessels here, the pinkish one. Stroma, so again stroma, these are the supporting structures. This is olfactory neuroblastoma or esthesioneuroblastoma. Well, this may be like resident level, but good to know, and this is beneficial, especially if you want to go to pathology someday and or ENT. Yeah. Another, we go to the next one. An uncommon tumor that may occur in the nasopharynx, the salivary gland, or in other midline structures in the thorax or abdomen, associated with translocations that create fusion gene, PRD4 or NUT. We have the not midline carcinoma. Now next, this cancer is associated with EBV infection or Epstein-Barr virus infection, diets high in nitrosamine such as fermented foods and salted fish, as well as other environmental insults such as smoking and chemical fumes. So we're seeing here this nasopharynx, nasopharyngeal carcinoma. So what is the associated virus or infection? Caused by EBV or Epstein-Barr virus. There are three patterns of nasopharyngeal carcinoma. We have the keratinizing squamous cell carcinoma, non-keratinizing squamous cell carcinoma, and undifferentiated basaloid carcinoma. So for keratinizing, we have the keratin pearls. If we see this in the microscope, these keratin pearls with malignant squamous cells. So keratinizing squamous cell carcinoma. For non-keratinizing, of course, we don't see these keratin pearls. We only see those malignant squamous cells. So squamous cell carcinoma, non-keratinizing. For undifferentiated, we will go to that. Nasopharyngeal carcinoma is associated with what organism again? Epstein-Barr virus. For undifferentiated basaloid variant, this variant of nasopharyngeal carcinoma is composed of large epithelial cells with oval or round vesicular nuclei. So don't be overwhelmed when that is described. So let me just repeat that. This carcinoma is composed of large, so watch for my cursor. These are large epithelial cells with oval and round vesicular. If you notice, there's some clearing here, and the nucleoli is very prominent, the pinkish one, and indistinct cell borders. As you can see, some borders are not prominent and forms a syncytium-like or like they are matted together. Scattered are abundant mature lymphocytes, these dark cells, small cells, predominantly T cells. The diagnostic test for nasopharyngeal carcinoma to detect the Epstein-Barr virus is through PCR or EBV encoded RNAs. Which is the most sensitive or radiosensitive, meaning they are susceptible to the radiation therapy? Is it the undifferentiated carcinoma of the nasopharynx or the keratinizing squamous cell carcinoma variant of nasopharyngeal carcinoma? So which is more radiosensitive? It's the undifferentiated carcinoma. Next is we have the laryngotracheobronchitis in children, in which the inflammatory narrowing of the airway produces the inspiratory stridor. It's called CRU in children. So as you can see here in this diagram picture, there's the larynx or the voice box and the windpipe, and if you have this inflammatory narrowing of the airway, this produces this inspiratory stridor. If you can search it also in the YouTube, it's this wheezing sound or this high-pitched sound during inspiration. So this laryngoepiglottitis can be caused by following organisms: respiratory syncytial virus, the Haemophilus influenza, or beta hemolytic streptococci. Also called polyps, sometimes develop on the vocal cords, most often in heavy smokers or in individuals who impose great strain on their vocal cords. These are called singer's nodules. These are also called reactive nodules or vocal cord nodules. So this is the picture from Robbins. We have here the singer's nodule. And in the following slide, we will discuss papilloma and the cancer of the vocal cord. So for this, we have the singer's nodule for those who strain too much on their vocal cords. So we have the next one, benign neoplasms on the true vocal cords caused by HPV type 6 and 11. These are soft, raspberry-like proliferations, rarely more than 1 centimeters in diameter. So here in the previous slide, we have here the raspberry-like, the papilloma. Histologically, these show multiple slender finger-like projections supported by central fibrovascular core. So these are like the stem. So these are the vascular and the fibrous, the pinkish one, fibrovascular core, and covered by an orderly stratified squamous epithelium. These are laryngeal squamous papillomas. Papillomas are usually multiple in children, and they are referred to as juvenile laryngeal papillomatosis. What is the most common laryngeal carcinoma related to smoking and alcohol use? It's squamous cell carcinoma. So this the lesion. So here we have the stratified squamous, the normal lining, and this is the cancer cells. Note the enlarged nucleus, and they are topsy-turvy and they invade the stroma. So mucosa, stroma, and the muscular layer. So what is the most common Bacteria. Now we go to the ear. Most common bacteria in acute otitis media, we have Streptococcus pneumoniae, non-palpable Haemophilus influenzae, and Moraxella catarrhalis. How about chronic otitis media? What are the causative agents? We have Pseudomonas aeruginosa and Staphylococcus aureus, or a fungus. Next, on the ear, we have the chronic otitis media. This is associated to chronic otitis media, non-neoplastic cystic lesions. So as you can see here, this is the middle ear, and then here there will be a cystic lesion here, 1 to 4 centimeters in diameter. They are lined by keratinizing squamous epithelium or metaplastic, meaning they have transformed into mucus-secreting epithelium and filled with amorphous debris from the squamated epithelium. These are the debris. And this is cholesteatoma. Next picture shows even a better picture of a forming cholesteatoma. You can encounter this in your rotation in ENT. Here is the gross picture. Next, this refers to abnormal bone deposition in the middle ear about the rim of the oval window. So we have there the oval window, and we have here the stapes. So there forms a bone deposition at the rim of the oval window into which the footplate of the stapes fits, leading eventually to marked hearing loss. It's like it's cemented to that. That is otosclerosis. Next is benign cysts usually appear on the upper, now imagine, upper lateral aspect of the neck along the sternocleidomastoid muscle. They are well circumscribed, about 2 to 5 centimeters in diameter, and histologically we find fibrous walls usually lined by stratified squamous or pseudostratified columnar epithelium. Typically contains lymphoid tissue with prominent germinal center. So I will show you that on the next slide. These are brachial cysts, cervical lymphoepithelial cysts. So the key words here are at the lateral aspect of the neck, and yeah, they are lined by stratified squamous, pseudostratified columnar epithelium with lymphoid tissue. That's what we can see here. So here at the lateral neck, brachial cleft cysts, and there are several types. You can see here at the upper portion, and this is the up to the lower, and then this is the sternocleidomastoid muscle. So if you find this mass along this line, you may be dealing with brachial cleft cyst. And the description for microscopic, we have the fibrous stroma and lined by stratified squamous, and there are lymphoid aggregates here and with germinal center. These are the germinal centers. The next one is another cyst, but now instead of having it at the lateral, we have them at the middle. There are cysts, also 1 to 4 centimeters in diameter, also lined by stratified squamous epithelium near the tongue or by pseudostratified columnar epithelium lower locations. So if nearer the tongue, we find them as lined by stratified squamous. If they are lower, they can be lined by columnar. Also, they may have lymphoid aggregates or remnants of thyroid tissue. So for this, we have the thyroglossal duct cyst. A while ago, we have the lateral one, brachial cleft cyst. Next, paraganglia. So these are clusters of neuroendocrine cells associated with the sympathetic and parasympathetic nervous system. That's why if you have this tumor like the pheochromocytoma, the patient will have elevated pressure, blood pressure. So the most common location of paraganglia is at the adrenal medulla. So this is your kidney, the adrenal medulla, or the adrenals are located at the upper pole. And this one, the most common location of paraganglia is adrenal medulla. For the most common location of extra-adrenal, meaning outside the adrenals, we have the head and neck. For the paravertebral paraganglia location, we have the organs of Zuckerkandl and bladder. So we have here a figure showing us where the organs of Zuckerkandl can be located. That's for the paravertebral paraganglia. Now again, for the head and neck, most common paraganglia location related to the great vessels of the head and neck is at the carotid body. This is the position of your carotid body. We have the carotid body tumor, and this is the prototype of a parasympathetic paraganglioma. They are chiefly composed of nests. Again, group of cells, nests. These are referred to as zellbollen. So this is the key word here. You hear the zellbollen, neuroendocrine. So we have this paraganglia. If it is in the carotid, so carotid body tumor. They are surrounded by delicate vascular septae. So septae or separations, like that. Okay, so to identify these neuroendocrine cells, we have this staining, immunohistochemical staining, chromogranin, synaptophysin, neuron-specific enolase or NSE, the CD56 and CD57. So this is just an example where the staining is the brown one, and this is from our Robbins. So we have here the nesting of cells with this surrounded by this septae, fibrovascular septae also. And you can either stain the cells or the lining. If you want to stain the lining, it is using S100 protein. And S100 protein will stain the sustentacular cells. Next one, we have xerostomia. And this is defined as a dry mouth resulting from a decrease in the production of saliva, presenting with atrophy of the papillae of the tongue, with fissuring and ulceration. So we see the fissures, like cracks. Mucoceles. Mucoceles are the most common type of inflammatory salivary gland lesion, and these are pseudocysts with cyst-like spaces lined by inflammatory granulation tissue or by fibrous connective tissue. So they can be lined by this they contain mucin and inflammatory cells, these macrophages, mucoceles. Sialadenitis is the inflammatory or inflammation of the salivary gland due to trauma, viral or bacterial infection, or autoimmune disease. Sialadenitis, salivary gland inflammation. And the most common form of viral sialadenitis is mumps. Sjogren's syndrome, autoimmune disorder with xerostomia or dry mouth, and keratoconjunctivitis sicca, dry eyes. Ranula. An epithelial-lined cysts that arise when the duct of the sublingual gland has been damaged. So if you block that duct, it cannot bring out the saliva, the mucus that is formed. That's why this cyst is formed. So sublingual, and if large, this can dissect through the connective tissue stroma connecting the two bellies of the mylohyoid muscle. That's why it can go down, and this can be called the plunging ranula. So it can either be here at the sublingual or here at the level of the mylohyoid muscle. Next, we have salivary duct obstruction produced by stones causing nonspecific sialadenitis. So we have here sialolithiasis. Next one is a common tumor of the salivary gland. The cut surface is gray, white, with myxoid and blue translucent areas of chondroid or cartilage-like. These are called pleomorphic adenoma or benign mixed tumor. And for the microscopic description, epithelial cells or epithelial elements resembling ductal cells or myoepithelial cells are arranged in duct formation. Ducts, or this one, the glands, acini, irregular tubules, strands, or sheets of cells in a background of loose myxoid. These are the myxoid pools containing islands of, this one we have cartilage, and rarely we have foci of bone. But in this picture we have the cartilage. Next one, we have a carcinoma arising in a pleomorphic adenoma. This is referred to as carcinoma ex pleomorphic adenoma or malignant mixed tumor. So just a note, the pleomorphic adenoma is a common finding in ENT. Next, tumor in the parotid gland. The Wharton tumor arises exclusively in the parotid gland. So take note, we have these three major salivary glands. We have the parotid gland, submandibular gland, and the sublingual gland. So the Wharton tumor, the most common site of this is in the parotid gland. It is termed papillary cyst adenoma lymphomatosum. And grossly, these are round or oval encapsulated masses, 2 to 5 centimeters in diameter, usually arising in the superficial parotid gland. The cut section show pale gray surface with narrow cyst-like or cystic or cleft-like space. If you can see these slits filled with mucinous or serous secretions. And microscopically, this Wharton tumor will show cystic spaces lined with double layer of neoplastic epithelial cells. So if you can see it here, this is the scanner view or the low power view. This is the higher magnification. So the upper palisading, again, remember the palisading, we have defense-like pattern. Palisading columnar cells with finely granular eosinophilic cytoplasm. That's why they are colored pink. Lower layer are cuboidal to polygonal cells, resting on a dense lymphoid stroma. Lymphoid meaning there are a lot of lymphoid tissue or the lymphocytes, sometimes bearing germinal centers. So if you can imagine here, like there's a germinal center there. So again, note double layer of epithelial cells. Upper palisading, lower cuboidal, and then there are lymphoid stroma. Next one, mucoepidermoid carcinoma. These are salivary neoplasms, particularly of the minor salivary glands. These are composed of variable mixture of squamous cells, mucus-secreting cells, and intermediate cells. Most common form of primary malignant tumor of the salivary gland, the mucoepidermoid carcinoma. And to identify this carcinoma, the basic histologic pattern is that of cords or sheets or cystic configurations, again of squamous mucus or intermediate cells, and the squamous features may have small to large mucus-filled vacuoles, mucin stains, reddish pink with mucicarmine. So this one, the mucin, they stain pink, reddish pink with the stain mucicarmine stain. Second to the last that we have is adenoid cystic carcinoma of the salivary gland again. These are uncommon tumor, 50% in the palatine glands. Histologic features are small cells having dark, compact nuclei and scant, or they have few cytoplasm. So here they are all blue, 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 and arranged in tubular, solid, or cribriform patterns. Cribriform or cookie cutter, reminiscent of cylindromas arising in the adnex of skin. So in between these tumor cells, there are hyaline materials, hyaline or pink materials, representing excess basement membrane. And their feature, the feature of this carcinoma, they invade perineural spaces. So these are nerves, nerve cells, the wavy nucleus, and these are the adenoid cystic carcinoma cells that invade these neurons or these nerve cells, nerve fibers. And the last one, we have actinic cell carcinoma. These are tumors composed of cells resembling the normal serous acinar cells. So these are the normal serous acinar cells of salivary glands. And this is the actinic cell carcinoma. These are arranged in sheets or microcystic, glandular, follicular, or papillary patterns, and they are mostly in the parotid glands. So that's it. Thank you very much. I will just send your quiz 30 minutes before the end of the class. Thank you.